This line graph tracks the incidence of congenital syphilis, detailing a 755% increase in the United States between 2012 and 2021. By 2023, the curve spikes to register over 3,800 active cases, including 279 fetal and infant deaths. The pathogen driving these statistics is Treponema pallidum, a highly motile spirochete bacterium. Transmission occurs when the bacteria cross the placental barrier. The spirochete uses its corkscrew morphology to drill through the placenta, directly entering the fetal bloodstream. A pregnant patient with untreated primary or secondary syphilis carries a 60 to 100% likelihood of transmitting the infection transplacentally. Intercepting this transmission is complicated by a central diagnostic tension. Evaluating a neonate for active infection is heavily confounded by the mother's own circulating immune response. Preventing fetal mortality requires clinicians to master stage-specific serological screening algorithms and deploy exact pharmacological protocols before the spirochete causes irreversible tissue damage. Identifying a true Treponema infection requires a bifurcated two-step maternal screening matrix to filter out nonspecific disease markers. This logic flowchart outlines the traditional algorithm. It mandates starting with a non-treponemal test, such as a rapid plasma reagent. If reactive, the protocol reflexes to a treponemal-specific test for absolute confirmation. This secondary confirmation eliminates false positive results triggered by entirely different biological events, such as pregnancy, autoimmune conditions, or disparate viral infections. A raw, reactive result on the initial screening is clinically insufficient. The laboratory must provide quantitative titer documentation to establish a baseline ratio. To accurately track the disease's progression or regression over time, subsequent quantitative titers must be recorded using the exact same assay type. The traditional algorithm's utility lies in its ability to establish a verifiable quantitative baseline for the mother's infection status prior to delivery. This secondary flowchart details the CDC's reverse algorithm utilized for mass population screening. It starts with a treponemal test. A reactive result must immediately reflex back to a non-treponemal test, isolating active infections. This sequence occasionally yields a discordant result. The initial test is reactive, but the reflex is non-reactive. To resolve this discordance, the clinician must order a second, completely different treponemal test. Definitively categorizing the maternal infection stage using these algorithms determines the immediate survival odds of the fetus. Precise in the delivery room, testing a newborn's cord blood to diagnose active congenital syphilis is clinically invalid. During gestation, maternal IgG antibodies passively transfer across the placenta into the fetal bloodstream. This immune transfer masks the pathogen's actual presence. Because of this passive transfer, an entirely uninfected neonate can still yield a positive syphilis serology. This split-screen readout illustrates the strict mathematical rule required for neonatal diagnosis, comparing the maternal titer directly against the neonatal titer. Active systemic infection in the newborn is only confirmed if the infant's non-treponemal titer is exactly 4 times greater than the mother's titer. There is one notable exception. If maternal infection occurred very late in pregnancy, maternal antibodies may not have formed yet. This scenario requires immediate cerebrospinal fluid analysis and long bone radiographs of the infant, regardless of the titer counts. Differentiating passive antibody transfer from active systemic infection dictates the entire course of pediatric intervention. The pathology of the disease is strictly bifurcated by age, beginning with early congenital syphilis, which spans from birth to under 24 months. Acute systemic presentations manifest rapidly. Infants often present with hepatosplenomegaly, an enlargement of the liver and spleen, and a distinct maculopapular copper-colored rash concentrated on the palms and soles. Clinicians will also look for syphilitic rhinitis, colloquially known as snuffles. This presents as a persistent, highly infectious, blood-stained nasal discharge. This pediatric radiograph illustrates the skeletal devastation caused by the spirochete. Osteochondritis induces diffuse, moth-eaten osteitis, and symmetric erosions on the tibia known as the Wimberger sign, which can cause painful pseudoparalysis of the infant's limbs. Early congenital syphilis drives aggressive, active tissue destruction. Left unchecked, it permanently alters the child's physical and neurological development. After a child reaches 2 years of age, the presentation shifts to late congenital syphilis, defined by irreversible structural and neurological sequelae. This clinical diagram highlights the defining diagnostic marker of the late stage, the Hutchinson triad. It consists of interstitial keratitis in the eyes, eighth cranial nerve deafness, and notched peg-shaped Hutchinson incisors. Prolonged osteoperiostitis leaves permanent bone deformities, including frontal bossing of the skull, an underdeveloped maxilla, or bulldog facies, and severe tibia bowing, saber shins. These late-stage presentations represent a complete systemic failure to intercept the pathogen during the viable therapeutic window. Eradicating Treponema pallidum requires a strict pharmacological boundary. Erythromycin is clinically inadequate, and tetracycline is strictly contraindicated. For maternal intervention, the protocol mandates a targeted regimen of benzothine penicillin G, administered intramuscularly. To effectively halt transplacental transmission, this maternal treatment carries an absolute temporal deadline. It must be administered at least 30 days prior to delivery. If the infant has confirmed or highly probable syphilis, the neonatal intervention requires aqueous crystalline penicillin G intravenously, or procaine penicillin G administered intramuscularly. The neonatal protocol is uncompromising. The regimen must last exactly 10 days. Missing a single day of therapy requires the clinician to restart the entire 10-day course from the beginning. Defeating congenital syphilis demands strict adherence to the diagnostic matrix, precise quantitative titer analysis, and the flawless administration of penicillin.